And thank you for putting into the chat info about yourself. I also have put in the draft agenda, and if anybody has any additional items they want to add to the agenda, or if there are topics that you'd like to add or questions to to be answered, please put that um, in the chat as well, or you can raise your hand and ask questions. And I know some people have told me that they probably cannot be here the entire time. I think that I've heard, for example, that some people need to leave about a half hour early. So the item that's in this agenda in the chat that says main discussion, which is talking about the manuscript that's under development. I thought that we should try to do that before people need to leave. And then the other items we can continue, and people who had to leave can access the recording and the PDF and notes. We don't have the visual note taker in our session, so just want to set expectations. We only have one visual note taker, and that person's in a different working group meeting. So we will, but we will have recordings and we will have PDF. So I don't see any items about the agenda, so I'm going to assume everybody's okay with this as the agenda. And again, if you have questions along the way, please do jump in. I don't want to be talking the entire time. You don't want to hear me be talking the entire time. So if we were in person, we're trying to sort of imagine that we're in person and what would we be doing and how would we be using this time together in a different way than the monthly working group meetings. And so we really did want to try to focus on discussions and hopefully people will not be bashful and will participate and unmute and so on. But I will start us off with some updates. And so I apologize to people who were at the working group meeting last week or at the MPI meeting on Monday. Some of this may seem redundant. It has been updated slightly. We've gotten some more data in. Thank you, everyone. I want to echo Dr. Stinson's words. If anybody didn't hear Dr. Stinson kick us off in the beginning of the day, um, he said that this initiative, this consortium, is the finest one that he's been involved with. And I think it is in large part due to the partnerships that we've formed together and the collaboration that we have formed across the consortium. And I want to applaud everyone for that. And thank you for that. So this is again the agenda, which is in the chat. These are folks in our research coordination data management unit, and our contact information. You probably have all of this, but just in case. We also have a ticketing system, which we were using more, and I think it's been kind of quiet lately, but this is a good way to help get an issue or a question that you might have to the RCC data team. And if one of the members of the data team can put the link into the chat, that's probably helpful for people as well. And then this is our roster. I know that we have more people attending today as part of the annual meeting than those who are on the roster. I think that this is up to date for our roster members. And let us know if we need to make any changes on this. And we will make all the slides available after the meeting. Whoops. This is from the intranet, and this is the 10,000 foot view of of the consortium, all 11 centers, all 46 projects that are R01 level projects. And so the order of these checkboxes is um, clinicaltrials.gov registration, data use agreement status, enrolling at least one participant, and this comes from clinicaltrials.gov, and transferring to the coordinating center at least one record. As you go across, where a green check means the goal is met, yellow arrows mean that it's in progress. A red X means that the goal has not been yet met and is late. And the gray means that it's not applicable or not yet due. Um, as overall, we're doing quite well. I think that, when Dr. Stinson made his comments, I think that that's in comparison to other large consortia that he's been involved with NIMHD funding, and that we, through your cooperation and partnership, have been able to get really far along in this process. This is a little more detailed. So this row is each project, and the launch date, the data transfer due date, the data use agreement status, transfer status, and the red cap metadata survey. We actually we're missing one of these we discovered last week, but we have since gotten that information as well. So from the original 30 projects, there is one data use agreement that we're still waiting for. Initially, the partner said that they didn't need a data use agreement for de-identified data, but then there was some leadership change and policy change, and now it is needed. And now there's a backlog of projects all trying to get data use agreements through. So that's been slow. We've gotten all of the data transfers at least once from the original 30 projects. We have two that are in progress, meaning that the data has been transferred to the coordinating center, but we are in the process of mapping it and putting it into the data warehouse. And then there's two that are late. And then there's one that didn't launch, and a couple of not applicable or exempt projects. Because they're not getting informed consent from individuals. And then the revision projects, similar setup. It's the same setup for the columns. So there's some launch dates that are in the past, but the studies we've been told haven't launched. And these data launch dates come from clinicaltrials.gov. So just a reminder to update that information once or twice a year. We have one more data use agreement, which is in progress and should be completed relatively soon. There's progress being made on that. There's been a data transfer that is also in progress, and then these that have been transferred, and several that are late, which may be complicated. This one is waiting for the data use agreement before it can be transferred, and they may be complicated by slowdowns in work due to terminations, which were then reinstated. And then overall, when we look at the consortium, 33 of the 45 projects have transferred data. 32 of the 34 data use agreements have been executed. And according to our records, 39 of the 45 projects have launched. And we have over 6,000 records. We have almost 6,300 records that have been transferred. So again, I want to applaud everybody for that. I'm going to check the chat and take this opportunity to see if anybody has any questions about those items. And I will say that the slides from prior meetings the PDFs are on the intranet. So and we will be putting these there as well. So if you haven't been able to access the intranet, please contact us and our team, and we will help you get access. Oops. Um, okay, I don't see any questions about data transfers, summaries, and where we are. Um, our lead on so next I'll give an update on the behavioral change technique taxonomy. Our lead on this has a class today, so is unable to join at this time. Um, I think, yeah, I think the class is actually exactly now. So I'm going to give an update, but there are no additional updates from last week. So this is mostly for people who aren't sure what this is or what we're talking about. Um, So there's a paper published in 2013 that Juan Espinosa from the SC3DRP Center brought to our attention actually at an in-person meeting in the working group at the in-person annual meeting in Bethesda. And it uses a taxonomy um, to classify interventions, behavioral change technique interventions, according to level, domain, content, etc. And what we're undertaking is a project and um, here is their taxonomy, and this is version one. And so we're undergoing a process to take all the interventions that are part of the consortium and identify which of these categories, because each could be and often is more than one category, which they fall into. Um, just checking the chat. Um, and yes, we wish that we were in person, but unfortunately, this is the next best thing. And unfortunately, we aren't able to be in person. Uh, we were told early on that it uh, would not be, it would be terrible if we had planned to be in person and put deposits on hotels and rooms and things like that, and then had to cancel it. And the political ramifications of that were too great. So there actually has been a revision to this last year in 2025. And so from 93 techniques, they've gone out to um, I want to say it's close to 150. I think it's like 146. And that they've done a revision. But since there's no data available yet on the revision for this process, we're still going to use the original one. Why are we doing this? We want to get an inventory of the interventions that are being done or have been done in the consortium. This is a good way for folks to report their own studies, include these terms in their studies and this taxonomy, um, and also potentially register your studies once they've been published on their website. And that this can increase the impact of your studies and may help with make it easier for folks to perform meta-analyses combining across studies to examine these characteristics of the interventions. So our plan is training large language model with the around 70 studies that are in trial registration databases and that have detailed information, and then train the model, and then use the intervention studies that are part of our consortium, have it give characteristics, and then have our group of experts within the working group. There are 3 or 4 people who have agreed to do this to evaluate whether around 10 of the trials were correct or not. And then that may require us to refine the the model a bit, and then we will send the classifications to the PIs for their review and concurrence. So it's taken a little bit longer to get the data we thought all the data was in just two trial databases, but it's five. And of course, they're all different set up, a different layout, different variables, variable names. And so it's taken a little bit longer to do that portion. But uh, Frank Wolf is working on that and is about to do this first test of the large language model on the trained data. Any questions about that? I know there have been a number of people in the working group who've been very um, excited about this project and been very collegial in wanting to help and assist and try some different LLMs. And we might even sort of stack them or use them in serial manner to get refine the classifications. Okay. I wanted to give a little bit of an update on NIMHD share, but I think on the agenda I moved this after the discussion because I really want to launch into the discussion and spend most of our time on that. So I will say we'll come back to this a little bit depending on how much time we have. But the consortium, NIMHD has instructed the consortium to use their data repository called Share. You can access Share here with this link. You would then log on to the Terra platform and you can you need to set up a billing account on Terra for Google Cloud and you get $300 free credits. The RCC is also in the process of loading some funds into Terra or into Google Cloud so that consortium members can utilize that for free, and that we're anticipating that that would last for beyond the life of the consortium, that the funds placed in there would extend for several years, so at least several years. So that should be a good way to do it. And initially, we would set this up as a uh, only accessible to folks in the consortium. And in any case, anybody who does access the data has to agree to the data use agreement that we have executed with NIMHD Share from the coordinating center, which includes all the terms and conditions of every project in their individual data use agreements. Um, oops, just checking the chat. Looked like there was something in the chat, but oh, there. Sorry. Okay. Oh, it's a direct chat. Thank you. I'm not going to read it, unlike some people. All right, so I will come back to share, and depending on how much time we have today, that will be how much time we spend on that. And then, in addition, we will have someone from the NIMHD Share team give a webinar that we will invite everyone in the consortium to. And I also have forwarded their thinkathons, that's what they call their webinars, information about their next thinkathon, which I believe is on March 18th. And if you didn't get an email from me earlier in the week, then let me know and I will forward that to you as well. Um, all right, so now let's move on to the manuscript. So this is a manuscript focusing on recommendations for common data elements for future upstream multi-level interventions to reduce disparities in multiple chronic conditions. This arose from our first in-person meeting, the idea of this in Bethesda And I believe it was Felicity Enders who brought this up, and she initially was talking about adding additional measures to the current CDEs. But it quickly became apparent that given the complexities with data use agreements and the data that we currently have and data use agreements that we currently have are all for de-identified data, that it would be much more difficult to include other data. So this then began a shift to thinking about the future and a future heme renewal, or just future research for anyone working in multiple chronic conditions and to reduce health disparities. We then, after the in-person meeting, began including this as a regular item in the monthly working group meetings. Um, but progress was slow, and so we had an all-day meeting between C2 Dream folks, their data core, and the RCC, and pushed ahead to come up with as much as we could in a day, and then brought that back to the working group for review, refinement, feedback, and edits. And then last year in San Francisco at HEAM, Felicity Enders presented this in one of the concurrent sessions, and there was really good discussion, particularly from community members. And so we again made changes to that. We also brought some of these discussions to the Network Community Advisory Board and got some of their helpful suggestions and observations and incorporated those. So we have been working on this paper. This is a framework, and this is the revision after getting some feedback from folks in the working group and as well as some of the MPIs of the centers. Um, and that is where we stand right now in terms of the framework and how we got here. And I think that we do have an updated version of the table. Sean, are you able to share? Sean Phelan from Mayo Clinic is, I think, that the lead for the C2 Dream Data Core. And he is going to be sharing some of the information. Felicity Enders had a conflict at this time, and so she's unable to join. But Felicity and Sean have been working on this jointly.
Would you like me to share the table now, or start into the slideshow and then transition to the table?
Whatever you think is going to be a better approach. It sounds like you maybe the slides first and then the table.
Yeah, I think probably. So, should I get started?
Yes, please.
Okay, let me figure out how to share. This will take me a second. Now, can people see the first slide with the
Yes.
heme? Okay, perfect. Um, yeah, so a couple of things. First of all, uh, a little bit earlier, Stuart said that the success we had is mostly due to the partnerships that we formed. But I really want to just take a second to acknowledge Stuart, Will Brown, Kathy Lanier, and the rest of their team at UCSF, and leading this was a really difficult, challenging task of forming these CDEs and getting all of the centers on board, and just really want to thank him and them for their leadership in making this so successful. So, um, and I'll reiterate one other thing that Stuart alluded to, and that a lot of the work for this has happened in sort of a small working group, but with feedback all along the way from other consortium members, from a lot from the data harmonization work group. And so just want to acknowledge that and really kind of share that this is a group effort with across all of the centers that are involved in the network. So this slide, I decided not to try to reinvent the wheel, so I'm repurposing one of Dr. Ender's slide decks from when she presented to our center. So you'll have to excuse me if I sometimes need a moment to stare at a slide and figure out what it's supposed to say, because it's not my content, but we will all do our best. How do I advance? Here we go. I thought I should let you know who you're talking to. So I'm Sean Phelan. I'm a co-I of C2 Dream and the Data Hub lead, really along with Dr. Enders. I'm also a professor of health services research in the Division of Healthcare Delivery Research at Mayo Clinic. So the current common data elements, you'll all recognize this research framework. The current common data elements really map well onto this, and in the next slide, we can see where they sort of map onto. Household resources, tobacco and alcohol related behavior, all of these other gray boxes sort of fit into the cross sections of individual, interpersonal, community, and societal. A couple of things to just point out is that there are things that are not represented here. For example, some outcome variables, including kind of upstream and downstream outcome variables. And then really this sort of box over here next to comorbidities, there's not as much kind of individual biological information that we'd like to see in there. And so that's where we started this process back at the HEAN conference in the DC area. So the goal, we have a lot of really meaningful common data elements. The goal that we started out with was to try to make them more meaningful and try to make it maximize the value that we can get out of this being a network and not just individual centers. We've had stakeholder input along the way from our community groups, both at the network level and at our centers level. The working group, obviously, the data harmonization working group, and from MPIs and other people at all the centers. So I will start with the premise and move into the implications, and then finally the measures. And hopefully it won't take too much time here. But one of the sort of concepts or things undergirding a lot of this work is that demographics are partly, as we all know, a proxy for a lot of other things that connect demographic information and really drive in a causal way health disparities in chronic disease. And so those things include genetic ancestry, which is only loosely correlated with the groups that we call race, or the social constructions that we call race. As we all know, there's more variation within those race groups than there is across them. Social and structural determinants, including things like discrimination, other interpersonal factors, structural things we're all aware of, like redlining and other barriers. Clinical calculators and clinical overshadowing, and ways that race, and especially stereotypes about race, can drive healthcare decision making, and assumptions about all kinds of things related to healthcare and self-care. And then finally, there's sort of this last mediator, moving just before chronic disease disparities, kind of the cumulative effect of all of those stressors on health is as accelerated aging or as the cumulative effect of stress, allostatic load, another way to kind of describe it. So some of the implications, we set out to build a model. Now we started with the NIMHD framework, which the boxes where the rows and the columns meet. We really wanted to transition that into more of a process model that shows the inputs, the outputs, the outcomes, the health disparities is kind of the ultimate outcome, and then the various kind of mediators that connect those things together. So both upstream outcomes and downstream outcomes. Um, and this simple model kind of represents that. The framework that we started with when we built this model is essentially a stress and coping model, which most of us are familiar with. That there are all of these factors that are stressors from different levels, and they are associated with health outcomes if they are beyond our ability to cope or manage that stress. And that'll be more clear as we go through the slides here. So it's very similar to this. It's just reversed. Societal, community, interpersonal, individual is just left to right now instead of right to left is left to right. And so here, kind of building on that stress and coping model, that these factors all contribute to chronic high stress, which feeds into and also is a result of intrapersonal factors. These intrapersonal factors include biological and physiological processes like allostatic load, like the results of the accumulation of stress, and those coping behaviors that if we have them, in sufficient quantities and sufficient amounts, can limit the effect of chronic stress on these biological factors. But only if if stress exceeds our ability to cope, these biological factors get worse. The stressors that we're focusing on fit in these three boxes: interpersonal factors, including experiences inside the healthcare system, personal experiences, experiences in the family and community, institutional factors, including factors related to education, employment, justice system, but most especially in the healthcare system, like availability of services and access to services, and patient provider concordance on certain important demographic and important group memberships. And finally, structural factors, including socioeconomic position, place, context, living and working conditions, housing, education, employment, all of those things, as well as in the healthcare system, like access, coverage, and workforce development. So here we have the beginning parts of the model, the process model that we use to develop this new proposal for common data elements. We wanted to add intervention opportunities to point out that there are places all along this process where interventions could occur. So they could occur at the structural level, institutional, interpersonal, or in these intrapersonal biologic factors, decreasing these or increasing our coping strategies, our coping resources. So now that is our conceptual model. And then we're going to move into a little bit about measurement. So measurement when demographics are partly proxy and there are all these other factors that are really driving the connection between demographic factors and health outcomes. So what data to collect? This is a little bit of a decision tree that Dr. Enders created. If there's biological samples and the condition is heritable, measuring a gene of interest, if not biological markers of aging, stress, and chronic disease. And that's where we are here with our proposal. Is if the study is prospective, can participants visit the clinic or be surveyed? If the clinic, there's allostatic load assessment. In a survey, there, you could ask about contextual factors, social drivers of health, stress, and chronic disease. And if not a retrospective study, you can get some of this information from the EHR or registry data aligned with chronic stress. So this is a very, very busy kind of visual representation of different measures from on a scale of more invasive, more expensive, perhaps more precise, to less invasive, less expensive, and less precise. We don't have to really spend a ton of time here, just pointing out that that these are sort of the measures from which we chose from to map onto the proposed CDEs to sort of fill in all of the boxes in that conceptual model that we looked at. So here again, back to the conceptual model. A few things that I'll point out that are additions, differences. So one of the proposals is to add a measure of allostatic load, including blood pressure, BMI, and waist circumference, to include new measures of health behaviors, nutrition, physical activity, smoking, and sleep. Measures of chronic high stress, including the chronic burden scale, ACEs, life stressors, as sort of important mediators of this pathway, so that we can do analyses that kind of take these mediators into account. Adding some geocodes based on census block group to be able to better measure and assess the structural determinants of health. Up here in opportunities of intervention, this is the Michi taxonomy that Stuart mentioned that we're working on mapping each of our studies individual interventions onto. This is the same slide that Stuart showed with the 93 or so techniques for intervention. We added the Promise Global 2 as an individual level health outcomes. Added within this allostatic load, added the way to measure that allostatic load is based on a paper that I don't have here in front of me, but it includes measurements of HDL cholesterol, heart rate, A1C, waist circumference, height, weight, blood pressure, and C-reactive protein, which is a really important variable in this construction of allostatic load, and something that kind of we call out here because it requires to be captured prospectively or perhaps from a well visit if such a thing exists, but because it's often collected in response to infectious disease, it really needs to be collected outside, if possible, outside of that condition. So here's the model with orange boxes around what's new from our current CDEs. And we'll go through these on the table kind of more in a little bit more depth. So I believe that's the last slide here. This is not a complete list of the people to thank from this group here and from C2 Dream and from the coordinating center. But there's my email right there, or Felicity's provided her Blue Sky or LinkedIn account if people want to reach out to either me or her. So I will close. I'm going to stop sharing. Maybe I'm already stopped sharing.
You are still sharing.
I'm still sharing. Okay. Well, I don't know how to stop sharing, but I'm just going to pull up. You can watch me pull up the draft priorities. Are people seeing the conceptual model in a Word document now, or still
No, we're still seeing your PowerPoint.
Still seeing the PowerPoint? Okay. Let me close it. And
yeah, that's better.
share my screen 3. All right. I will maximize this. So this is the list of priority measures, the list of proposed priority measures for the renewal that Stuart mentioned earlier. And we'll walk through it, zoom in a little bit here, walk through it a little bit slowly, explain what's there, and then hopefully open it up to some discussion, some questions about individual items. Anything really that anybody wants to talk about. And I invite Stuart to jump in here with anything that he wants to add as we go. But
Yeah, so I put a couple things into the chat,
okay.
which is, we've tried to use reliable, valid scales, and we've tried to use the shortest ones that we can find that yield high quality information, and whether they're short form scales or single items. But if people are aware of shorter versions, for example, the example that Sean gave was instead of the Global Promise 10, there's the Promise Global 2, which is actually 4 items, but at least that's 60% shorter.
Yeah.
So those are the sorts of things we are concerned about burden for participants. And I'll also say that we've had some debate internally, like what is it? What is it we're doing? Are these requirements? Are these suggestions to NIMHD? Are these a starting point for discussions within a future consortium? And I think we've kind of landed on the last, right? Because on Monday, Dr. Stinson told us, they can't take anything from us to put into an RFA because we're already funded and it would be kind of like insider trading or self-dealing. So they are forbidden from doing that. But, and we're not anybody who applies for some future mechanism isn't being held to this, but these are so really what we're doing is we're making suggestions in that we feel like having some consensus on this will make it a lot easier the next stage when there's a consortium or a large group of people, teams and partners, community partners who are working in this area to use this as a starting point, but it is not something that we see as set in stone by any stretch of the imagination. So hopefully that provides a little more background on why are we doing this? What do we see its utility in the future
Mhm.
as being?
Yeah. Yeah, thank you, Stuart. So let's look at a little closely at this table. First, the columns here. It's organized by the construct, the domain, where it fits, the how we're proposing to measure it, when we're proposing to measure it. So REQ would suggest means that time point we're proposing that it be required, and optional OPT means optional at other time points. This column indicates whether it maps to share, which Stuart said we would talk a little bit more about later, but share, one of the things share does is outline requirements for common data elements, or at least concepts that need to be measured. A source for the measure. This column here changes from HEAN 1.0, describes whether it adds or possibly in some cases subtracts items from our current set of CDEs. And then here there's a column about notes. So we'll walk through this one subtable at a time. So under structural factors, the first construct is census block group. So we're proposing asking each study to use the US Census geocoder, either submitting addresses in a batch form or somehow asking participants to look up their own address and provide the geo ID under census tracts, which lets us know the census block, census tract, PUMA, all of those ways that we'd be able to construct measures like the multidimensional measure of structural racism, or what are some other ones? The area deprivation index, things like that. Um, Other structural issues, this time around the healthcare system, we have a measure of access to healthcare, including specific barriers to getting healthcare, and that's the part that adds the 7 items. Then this would be required at baseline. We have a single item, access to preventive dental visits, that adds an item. A a new way of measuring health insurance that actually removes 5 items, because in our current CDEs we use a longer Phoenix measure. I'll pause there at the end of the structural measures to see if there's any specific questions about the structural measures, or just things people want to share.
Hi, Sean. This is great work. I had a question about the access to healthcare. Is there a way to break out access to mental health care or other resources that would help with coping?
Okay, good. Yeah, good point. It's not, I don't think that's in here. I think the measure we're using is just broadly, do you have a place you usually get medical care? And then it asks a few questions about what are the barriers preventing you from getting medical care. But I don't think we have anything about access to mental health care, just dental health care. So let's take a note
Yeah,
about that. That's an
I think that's
important
a great
abstract.
suggestion. Do
Yeah.
you know of a specific item?
I do not. I
Okay,
was
we
just
can search.
yeah. The other thing is some communities may, have alternative ways of getting, support for their emotional well-being. So, community resources or spiritual resources or communities could also be a question. I don't know if these would be readily available from certain data sources, but they're constructs at least to be aware of that. Even if we don't find measures of them, we can at least note them perhaps for
Yeah.
future data collection efforts, or maybe identifying new data sources or next steps.
Yeah. Later in the table, there is a survey measure of social community cohesion that might touch on some of those concepts. So I'd be interested if there are additional things when we get to that, if you feel that it aren't covered by that measure, that we might consider. All right, moving on to institutional factors. We have our current measure of disparate healthcare quality, and that's the single item that we're currently using in the CDE, the current CDEs. Um, Barriers to healthcare access. This might be, I'm not sure the relationship between access to healthcare and barriers to healthcare access. So that's something you need to revisit. As you can see, this is a working document. There's lots of comments along the side that I have hidden right now. And one of those comments might be a question about the relationship between this measure and the one above. Here, so that's institutional factors, moving into interpersonal factors, experiences in the family and community. Here we have a sense of community scale, the brief sense of community scale, assessing needs fulfillment, group membership, influence, and emotional connection. And this is an 8-item scale. It would add eight items and be required at baseline. We have a short version of the everyday discrimination scale, just the 5-item version, which would be, so add 5 items and would be required at baseline. So now onto interpersonal experiences inside the healthcare system. A discrimination in medical settings scale, which is a 7-item scale from Monica Peak, that would be required at baseline. And so those are the interpersonal factors. Now into intrapersonal factors. A lot of these are the same or very similar to our current CDEs. The housing security is an additional item. It would add an item to the list. Unable to get housing when needed, required at one point. Financial security would add a single item to what we're currently using. Unable to attain resources in several different domains. So it's 11 items, but it's one more than we currently have in our CDEs. Health literacy is the same as our current CDEs. Social connection is, I believe, the same as our current CDEs. Again, required at baseline. Here, demographic and personal resources are mostly the same measures that are currently part of the HEAN 1.0 CDEs. There's one fewer race ethnicity question because now the Office of Management and Budgets combines race ethnicity into a single item. No change for sex. Gender identity, either no change or perhaps dropping that item. Age, no change. Sexual orientation, no change or perhaps dropping that item. Marital status, household size, no change. Household income is a measure that would remove 8 items from our current CDEs because we have a very long way of measuring income currently. No change for employment, education, English language proficiency, an added item for birthplace. 5 added items for food insecurity. 1 added item for disability status. And a large, and obviously this is something that would add a lot of items we need to sort of think about, but help needed with activities of daily living would add 16 items. And so this is one item. See, it says rec and rec, that probably because of the number of items that we have right now kind of earmarked as being recommended but not required. So here we get into the intrapersonal factor. Well, actually, let me pause right there and see if there's any questions on the intrapersonal demographic measures that mostly map onto our current CDEs. No? Okay, I'll move on. This is where a lot of the changes occur in these biological factors and physiological processes. So we're proposing that vital signs, body measures, be measured in the participants in all of our studies, or at least a subset of participants in our studies. So we retain the self-administered comorbidity questionnaire, so there's no change from current CDEs, or the Charlson Comorbidity Index can be calculated based on the EHR, if there's EHR data in the study. Medications and treatment for health conditions are the same as currently used, and that either comes from the EHR or from self-report. Here, blood pressure measurement. We're proposing that it be required at baseline and at the end of program, and that can be either prospectively measured through an in-person visit, or if available in the EHR in certain windows of time, can be pulled from the EHR. Height measured either prospectively or from the EHR. Weight measured either prospectively at baseline and the end of the program, or pulled from the health record in those same timeframes. The allostatic load measure. So the allostatic load measure comes from McCrory et al. It's a very influential paper describing a way to measure what is really difficult to measure, and that's the accumulation of chronic stress. And so it's a composite measure that includes C-reactive protein, resting heart rate, HDL cholesterol, BMI or waist to hip ratio, which we're now thinking of using hip circumference rather than waist to hip ratio, and HbA1c. So here's the details. Required measurement of C-reactive protein at baseline and the end of program. So this is a blood test, either a finger stick or blood draw. If available in the EHR, that's another possibility as long as it is available during a well visit check and not during a kind of active infection. Resting heart rate to be measured at baseline and end of program or from the EHR in the same time frame. HDL cholesterol prospectively measured at the same time points or through the EHR within the same period of time. Waist circumference prospectively measured, same baseline and end of program or from the EHR. And A1C prospectively measured at baseline and end of program or from the EHR. So those are some of the largest, I think, impact changes from our current CDEs, which don't include physiologic measures. So I'll pause there and see if anyone has any comments or questions on that part of the proposal.
So I'll just chime in and say that when we met in San Francisco, there were a lot of questions about these measures for studies that are not in healthcare settings. So studies that are taking place in the community. And so one of the ways the team has focused on addressing this is using data from electronic health records that may be available for studies that are linking to them, as well as using test kits, so point of care test kits, as Sean mentioned. So this is a way that the team has heard from the community partners and from investigators working in the communities and tried to come up with a way that would still yield uh, high quality data on these measures, um, but that would not be require healthcare visits.
Thank you, Stuart. All right, and I'm trying to follow the chat. I don't see any. There's a lot of questions related to from before about mental health care access and dental care access, but I don't see anything specifically about these physiological measures. But I encourage everyone to
Looks like there was
just
a.
speak up. Oh
It
yeah,
looks
I
like
see.
Juan has his hand up.
Juan, please.
Yeah, hey, I don't know if there's been discussion of potentially for at least the biomarker pieces like hemoglobin A1C, et cetera, of I realize it would require, as long as we're making recommendations of doing that centrally so that, whether, that there's some CCC/DCC style function that, sends out. We've done this for some studies that I've been associated with where we, will say, there's now hemoglobin A1C cards that you can mail to people and they can mail them back, right? Like similar to like blood spots. There's Tasso style solutions, although our experience with Tasso in pediatrics has been less than stellar. In adults, they seem to work reasonably well. So there may be a role for like addressing the biomarker piece of this through some central DCT style, right, distributed community trial approach, where like one, as long as you get addresses from people, great. One team just sends out all of the kits. The testing happens at home. They send it back. All the testing gets run.
Yeah, very interesting idea. Stuart, any response to that?
Yeah, no, I think that's a great idea. I start to put into the chat, and I think it's not something that we've done in this particular coordinating center, but it's something that we've done in other kinds of coordinating centers, and that we have colleagues here who have done that, and that would be potentially something that we could add, and perhaps the biomarker portion would be a subset of participants from each project. The other thing to think about for some of these measures is, like, do we need them on everyone who's part of a study? And maybe it's, maybe there's some uh, evaluation of that aspect of it over as we move forward.
Yeah, thanks, Stuart. Yeah, wonderful idea, Juan. Thank you for suggesting that.
Yeah, sure.
Yeah. All right. So other intrapersonal factors, and these would be the survey version of intrapersonal factors. Most of these added items from our current CDEs, or at least different ways of measure concepts that we have in the current CDEs. So we're proposing to use the mini EATS because it's just the shortest validated one available for measuring nutrition, and that would add 9 items. Again, it required at both baseline and end of program. Physical activity, the NHANES Pack K for physical activity would add 2. So it's 4 items, but would add 2 from our current way of measuring it. Smoking, the NHANES SMQ for nicotine exposure is 4 items, would add 3 from our current single item measure. Sleep is not currently being measured, but we're proposing just a single item. Alcohol use is a single item, no different from our current CDEs around alcohol use. Substance use is 2 items, no different from our current CDEs. Stress is where several added items come from, because when we looked at the model, we really don't have that kind of process, those mediators of the stressors, of the demographic factors, of all those other things in our current set of CDEs. So we're proposing 2 measures. One, the ACEs measure, really commonly used measure of childhood experiences that are stressful. It's marked required with a note to consider omitting for populations where community input indicates the measure may be overly distressing. So that's a caveat there. That's a 10-item measure. And then quite possibly, or at least what I consider a really, really important measure, is the chronic burden scale as a way to measure exposure to chronic stress over the life course. And that's a Bromberger and Matthews measure. It's a 15-item measure. So it's longer, but I think would be a really meaningful upstream outcome or mediator in these new proposed sets of CDEs. And I will stop there because this next table are just recommended and optional priority measures, mostly things that we considered, things that people suggested that are we thought were good ideas, but maybe didn't rise to the level of something that we want to propose requiring. So just for some, I will maybe slowly scroll down. We've got liver function, kidney function, other measures of stress that we decided under some duress to remove and just stick with the ACEs and the measure of chronic stress, but some other measures that are suggested or optional. Some information about the intervention that the study might be using that would be replaced by the Michi et al. Program that's currently being developed, and that's it for optional measures. So I'll come back here to this table of proposed required measures and open up the floor for any questions, ideas, observations, comments. Hopefully it would be great to have a discussion about this, all of these items as a proposal for renewal. Stuart, anything to add before we do that?
I don't think so. So we have about 10 minutes left. And yeah, I mean, I think that we really like to hear from people, your thoughts on this is what's your, what are people thinking?
I mean, I think it generally makes sense. I forgot to ask, but I'm going to assume that it's true. And most of these are, openly available, freely licensed. They don't require. There aren't any instruments here that require like a paid license or anything like that.
Mhm.
I don't think so.
I don't think so. I will
Yeah.
say a cautious yes.
And that's definitely a consideration. Yeah, philosophically, we're for open data and open instruments.
Yeah.
There may, however, be on some of them, the ones we were looking at, there were requests in the original manuscript that if you used it to cite it and gave recommendations for how to cite it, so we should dig into that.
Good point, Caroline. Thank you.
Yeah, always reasonable. Yeah, that makes sense. And were you, or is the thinking it'd be a similar approach of, a coordinating center developing a template RedCap project. Those RedCap projects would have the instruments built into them and the right databases for adding and collecting the various instruments and then disseminating that RedCap project for individual sites to use.
Yeah, we can certainly do that. And even for the biomarkers, although I really do like your idea of having centralized biomarker.
Yeah.
Be, as I put into the chat, I think, there's a whole nother issue with the variation among labs, or
Yeah.
among brands of point of care tests.
Mhm.
Yeah.
Just within our center, we found huge differences between the University of Minnesota and Mayo Clinic in charges for labs. So nationwide, I'm sure the variation would be extreme. It would be great to, think about a centralized way of doing it.
Yeah. What was your experience? I know, Stuart, we shared a little bit, with geocoding and sharing census level data, and how might that be? Like, what would you think of doing differently for the next round?
Yeah. So as I put into the chat, the NIMHD, NINR share CDEs includes residential zip code. And so therefore it won't be de-identified data, which is what the RFA for these awards this time said. So it will be a limited data set. And but I know in particular Bert Chantarat, who's part of C2 Dream and works a lot with Sean, he's done quite a lot of work with geocodes, and zip code is, as many people know, very problematic. It's really only set up for the convenience of the postal service to deliver mail. And however, it's easy because most people know their zip code and no one knows their census tract number or census block group number. But you can use the tool. You can't see the link, but where it says source and U.S. Census geocoder on the Sean's screen, you can use a tool that where you put in a residential address and you get a single one at a time, or you can do it in a batch up to 10,000. So that's something currently, because it's de-identified data, that we are in the process of finalizing how we're going to send that to the projects and centers to ask those who have residential address to geocode the data and then merge census tract to our neighborhood archetype variable that we created, that is one of 11 types. And then that neighborhood archetyped variable would be sent for each participant, but it would not include any PHI because it doesn't include zip code or uh, census tract or anything like that.
Got it.
So that's more complicated. It's more
Yeah.
straightforward if we already know going forward, you need to get zip code. So in addition to zip code, we would get, or instead, we would get, each project would get the address and then geocode it.
Yeah.
Yeah, no, it makes sense. I think the one of the things that we, at least that while I was still at CHLA, we ran into even using the census, a US Census geocoder, because technically, right, you're taking a patient's PHI and putting it into like an open public API or identifier. No, it's not PHI, it's an identifier. So we had to switch to using like our, an enterprise license of ArcGIS, which was just another level of complication. But so the one of the reasons I bring it up is that last month, Mark Hoffman's group from Children's Mercy, they released an open source containerized wrapper around Dagaz. Like Dagaz is great, but it's a lot of work if you're not familiar with it. And right, open source geocoder. So they put a kind of a nice Docker container around it with some web wrappers, and made it available through GitHub. So that might be potentially a solution. A future network would probably have a lot of different kinds of sites, and some are like very sophisticated and have ArcGIS and know what they're doing, and some might be really restrictive on using the census geocoder. And so like some open source tools like this might be like a nice solution for like a specific subset of potential participating sites.
Yeah, thanks. So that was Hoffman's group?
Yeah, Mark Hoffman.
Mark, okay.
Yeah, and I put the link to the paper and his GitHub in the chat.
Oh, fantastic. Thank you.
Mhm. Yeah, just like published like 4 weeks ago.
As primarily a Teams user, does the chat live on in Zoom after we end the call, or are we able to
It
capture?
can, yes. So I know we're recording this, and you can then create a transcript from the recording. Um, I just turned the transcript on, but I think it may have been on already.
Okay.
And then we can save
Usually
it.
the Zoom account, when it generates a recording, it'll automatically also save the chat, like in
Yeah.
your Zoom admin panel.
Yeah, the chat for sure. Sorry, that's what you were asking, not the transcript. Yes, the chat does go to whoever the um, host is, and sometimes the co-hosts. So yeah, I have lots of chats that are saved, and
Okay.
that's sometimes why I put things into the chat that people are saying, so that we have that for it's easier to get that piece of information later, almost like a note taker. Um, so we are almost out of time. I think pretty soon someone's going to come in and tell us that we are out of time, or that the countdown, I see at the top it says remaining 1 minute 15 seconds. So um, don't know if we have any additional comments, uh, questions. I think this has been really helpful. I hope that you have found this helpful. I'm not interpreting silence to mean agreement. I've learned that that is not a good way to proceed. It's not a useful thing in life. It's not a good way to build consensus or trust. But I will interpret silence as that people are considering this and ruminating on this. We are still welcoming feedback to the manuscript as it's finishing development. And I want to thank everybody for choosing to come to this work group breakout during this session. Um, and our next meeting is March. I think it is March 17th. And we're getting a message that we need to close the room. So our next is March 17th. Yeah, St. Patrick's Day. So again, thank you for participating, and please feel free to reach out, provide feedback about any of these items, and we will give you more updates in the next time.
Yeah, thank you, everybody.
Thanks all.
Thank you.